and I move around a lot. So I may divorce myself from the microphone. I apologise, it's just the way I am. It's a great pleasure to come and talk to you all. I've had a very fantastic but moving personal journey with ALD, particularly meeting Karen and her family, and of course the two boys, Cameron and Alex, a long time ago. You think it was 14 years ago, 13 years ago, around then. So a long time ago. And I'm very pleased to come and help, because I think the role of the neurologist is absolutely critical in children and adults affected by ALD, AMN. Mainly to make sure everyone understands we don't do very much. And that's a critical issue, is to making sure that everybody understands who does what. And I think this is where the neurologist comes in. I'm a paediatric neurologist based up in Cambridge, covering all of East Anglia, including Hitchin. And I'm going to start off with the first thing that we tend to do. So we're based in a central centre in the UK, in Cambridge. Andrew's kindly come up from Bristol and covers the whole of the southwest with his team. So we're based in a capital of that region. But we can't get everywhere. So if you think about children who are presenting, or adults, they'll initially present to their GP, and then through to their paediatrician, and then hopefully have a prompt referral and diagnosis. But of course, we all know that all metabolic disorders take too long to diagnose. That's absolutely the same all the way across the disorders. And quite often there is serendipity with the diagnosis. You know, if by chance you come into the hospital on a day when the doctor around has seen the condition before. So we're looking at doing better with this, and that's why those discussions about newborn screening are really interesting, because even if you have key clinical signs that you say you must do this test for, we still know these tests are often not done. So the neurologist should ensure that secondary and tertiary level services identify the disorder. So that's the first thing. So we develop training and systems that will identify people who are affected. So if a 30-year-old man develops slightly stiff legs or bladder instability, or a child of 6 becomes a boy, becomes progressively unsteady and with visual impairment, the neurologist should make quite sure in his region that the secondary level doctors immediately refer them up, quick, because these conditions advance very quickly, and we want to see them within a few days, and we want to do the test quickly. And the critical thing there is that we need to do our test quickly as well. So if the referral comes in for a child who's 6-year-old boy who's deteriorating on the 25th of August, I'll be away for 2 weeks after that, and then when I get back there'll be a lot to do. So we need to ensure a system comes if there's a degenerative picture, a child is ever losing skills, that they're seen very quickly within a few days and first steps are taken. I've mentioned MRI and very long chain fatty acids there being the first stage. But you can see here that the MRI is a very characteristic picture in ALD, and that's something that we would expect to be done in our service within a week or so. The good news in the NHS is the normal waiting list for an MRI is many months long now. So you either do it urgently or you wait many months. It's kind of easier than the olden days where you had to wait 4 to 6 weeks with a quick one. So children who are degenerating do need an urgent MRI, because there may be a window for disease modification. And in general, most people go for the MRI straight away for 2 reasons. The first reason is that it has the greatest yield. So it's very sensitive to picking up an abnormality, but not very specific for telling you what the abnormality is. Although if you saw this in a boy of 6, you would be going for one test very quickly, which would be the very long chain fatty acids. The other reason we do MRI in kids actually is because they probably get a general anaesthetic for it, and we can do all our metabolic tests first. So there's a kind of logic, get the MRI back and then focus in on which test you want to do, but then you have to bring the child back and do a needle, so it's easier really to do it in one sitting. And certainly VLCFA would be on the core investigations which we do straight away. They're in my hospital, I'm sure everywhere in the UK, Andrew, they're very easy to get and very quick turnaround for those. So I think about 4 or 5 working days in my centre for those. Is that the same in Bristol? About that, yeah. So we can get that result back within a week of the MRI. So the child comes in, you get a week with an MRI, and a week later, you've got within 2 weeks, you're well on the line for diagnosis if you identify the problems. And the identification, thank you very much, the Harrison family, for the photos. The identification can be a little bit difficult because actually the visual failure, which makes a boy a little bit unsteady, it's somewhat difficult to really understand why they're unsteady. So hopefully, though, with the loss of skills, you will initiate the core investigations. There will be very quick referral up to the tertiary centre and quick investigation. And again, my role is to make sure that this system happens well, and to look at the system. And when it's very slow, when we have a child that takes 9 months to diagnose for an easy diagnosis these days, like ALD, you know, why did that happen? Why didn't we go quicker and make sure it doesn't happen again? So we come out the other side, and we have a child who has a confirmed diagnosis, and then I will be working with a lot of other specialist services. I will be immediately ringing my colleagues. We work with Evelina, the Children's Hospital, to get their expert advice on metabolic imbalances. There'll be questions around Lorenzo's oil, etc. I want them to confirm the diagnosis clinically because I'm not competent to do that from the VLCFA. But I'd also be speaking with a geneticist who will be doing the genetic mutation as soon as possible, because we're really trying to tie this up and keep things moving because there's a lot of work to do. And then, of course, I might lose the child because I'll send them down to Bristol, and then they will have a very busy time in Bristol because there may be a candidate for transplant, and there'll be a lot of conditioning, etc. And things can get a bit lost at that point. And this is the second role of the neurologist, because I think the need for the child is sometimes not a super sophisticated research trial into the benefits of transplantation, because actually what the parents may be struggling with is the child's behaviour, or the child's sleeping, or the child's mobility. They are the practical issues that are driving the family mad. And I think Karen will attest, the first part of your journey was very, very tough. For all of us. I learnt a lot in it myself. So my own feeling is that there are a number of symptoms that need to be addressed urgently, and the neurologist should be able to do that. But in my colleagues' defence, I think if they've never seen ALD, it is a particularly vicious and quick-moving, the cerebral ALD. It's very difficult to keep up with the symptoms as they come along and support the families adequately. So in our team, we'd certainly be discussing that amongst all 6 of us, and I've probably seen more than my colleagues, and I would be signposting them into things that are, again, they better be prepared and move quickly for it. The good news is, unlike in the adult services, we do have excellently coordinated multidisciplinary care these days, although I think Karen's journey at the beginning was rather different. The coordination and integration of the multidisciplinary services just wasn't there at all, was it, Karen? So some key ones that the visual failure is absolutely typical. So there's no reason why you can't refer through to visual impairment services day one. If it takes them 6 months to see, then people can do it when they come back from transplant assessments. But the visual failure in particular can lead to great disability and distress. And I'm going to come back to management of distress in a child losing vision and other skills. So the child's getting very frustrated, bored, lonely, and he can't see adequately or as well to the toys previously. His world's changed, and we need to adapt quickly. Now, these things are things that are core things for a community secondary-based doctor to do. They know what to do, but my own experience is that they will be like a rabbit in headlights. It'll be a really frightening, intimidating picture. So they need my assistance at tertiary level just to signpost this up. And when they're saying, I don't know what to do, you say, well, what did you do last time you had a 6-year-old boy with VI? And they'll go, oh, I did this, this, this. And you go, yeah, that's all you need to do here. You don't need to invent a special route for boys, because the best thing actually is to focus on the symptom and treat the symptom rather than a scary diagnosis. We're not asking the secondary guys, you may only see one child ever with ALD, to become experts in the pathway. we're using their expertise on existing symptom management. So the first I mentioned was VI, visual impairment. The next, and I think Karen will back me up, the irritability and distress was the really big one that we all found very difficult to manage. And that really, really hits families. And I think the request was immediately for medication from everybody. And I think it'd be fair to say that Karen wanted some medication to help. And I think all the communities who were involved were screaming for medication to help. Did the medication help much? No, that's the problem. It doesn't help much. And I think you have to have an honest discussion very early in this journey to say that medication is not going to be the answer. The type of dosages you need to really reduce distress of general anaesthetic, and you're just not doing it. My memory was walking around the park was the single most useful intervention we could do. Still is, there we go. So there are simple interventions we can do, but at this point when a family are coming to terms with very big news and are not trained to deal with a child with complex neurodisability, and they've had to adjust within 6 weeks for that, I think saying to families, actually taking your child for a walk around the park is not only okay, it's good for everybody, is a simple thing you can do. And again, it comes back to me giving permission for the local team, because they've done that 1,000 times before, and anyone who's had an irritable newborn baby, when they get the colics between 6 and 8 weeks, and maybe the baby's 3 months old in June, what is dad sent to do? Take them around the park in the pram. So these are little strategies that it's more that everyone knows what to do, but it's just empowering people to do it. And I think the distress in particular needs a complex plan with discussion between the different supportive people in that journey, because it's not primarily fixed by any one person. The physio will help, the occupational therapist will help, speech therapists will help, and I'll talk about some of the other ones within the MDT who will help. So the neurologist's role is to empower a multidisciplinary team to do what they already know how to do and do it well. And critical parts of that would be dietitian, because no one likes starving, and if you can't see your food or you can't get your hands to your mouth, then you will be hungry, and if you're hungry you will be distressed. And even if you can get it to your mouth, you may not be able to swallow the food efficiently, so we need a speech therapist who will help children both with swallowing their food, but also with communication at a time when they're finding that very hard. The physiotherapists are, as a neurologist or a community paediatrician, are our right-hand men or women. So they're the people who really help us, and they tend to be most busy in people's houses. They have the most frequent contact commonly, and so they're getting them in, and they tend to immediately work with the OT who's doing things like chairs, adaptations. I think the other feeling for families is once you start to get them working together, once they first come in the families, I think it's a bit like a flood of people coming in, you're not quite sure what's everyone's happening, and every time you try and have a bath, get out of your nightie and have a bath or a shower and get dressed, there's another ring on the bell, and you've got another visitor, and you have to work all these relationships out. But eventually they are the cavalry as they coordinate and synchronise. I'm talking about the synchronisation is the secondary lead in neurodisability, must take a lead role, as the tertiary neurologist will not be able to deliver the care that these children need. And that goes the same for my metabolic friends and my oncology friends and my endocrinology friends. I think it's absolutely critical that we empower somebody who can really coordinate day-to-day therapy input that really helps families. Of course, the stem cell transplant may be a fantastic thing to do, but ultimately we still need all these people working, so there's nothing lost by putting in. And even if a child has a very successful transplant and never has any difficulty swallowing, there's no speech therapist in the country who would have any problem at all at assessing a child. And the physiotherapists, for example, the child has normal gait, can see them at school in a normal sports period, so it doesn't have to disrupt family life. The next one I mentioned was this distress issue, and confusion. I think this was a critical part we had in the journey there, and trying to anchor a child back into real life is more difficult than you think it is, because there's some key ones. If you've got visual failure, for example, you no longer have light dark, and that's dark is I'm going to bed-ish, light is I'm getting up and going to schoolish. And if you lose those, those critical stimuli, life starts to get rather confused. So there's lots. And we don't need to make a special route for boys with ALD, because we treat it as it would for anyone. And I often take people back a bit to say, well, what do you do with Granny when she's a bit confused? We make sure the world is easy to navigate. It's very clearly signposted. We're very supportive, and people are supportive of kind. And from my team, sometimes I help secondary level leads to say it's very akin to our children who've just suffered a traumatic brain injury, where often they're quite disorientate. And in fact, ALD is like a brain injury, isn't it? It's a rapid onset process that makes your brain not work so well immediately afterwards. So we would talk them through. And then the last thing to say is medication treats confusion poorly. In fact, it's a sackable offence in my department to medicate confused, aggressive children. But everyone asks for it, but they never get it, because actually it just makes everything worse. Because if you're a bit confused and you give someone diazepam or morphine, what happens to them? More confused, more distressed, more drugs, and you rapidly get into a vicious cycle. So it's really unhelpful. But we have very good journeys. Bristol, for example, have a huge traumatic brain injury team with a lot of really expert workers who would definitely be able to signpost both local and regional services on how to support a family with a child who's getting confused, and as a result of that is becoming distressed and may not be able to work with the specialist services. I've got one other thing on my slide that's absolutely critical, other than all I've mentioned. Has anyone idea what might be on the next slide, which I think is a critical issue for families coping with boys who are having a quick deterioration or have deteriorated previously with ALD?
Taking care of themselves.
I think independence is absolutely critical, and I think that is particularly important for anyone who has motor movements. One I remembered. Aha, you beat me to it, Karen. You've seen the slides there.
No, I haven't. I just know.
Sleep. So there's two advantages to sleep. One is we all need it. Karen needed some sleep. And when I first got involved and we had to go down to their house, we had to shame the local teams turning up because they weren't engaging. So the guy came down from Cambridge to the house, so everyone turned up at last. And the cavalry, although it was a relatively small team, did start to get in. But we all need it, everybody needs it. And the thing to remember is that for the child, if they don't sleep, they're irritable and hyperactive and horrible. And there are a couple of other things that get better if you have dystonia. It will completely arrest during sleep. So we need to achieve sleep. Anyone who's had a small baby will know that achieving sleep in children is more difficult than, easier said than done, isn't it? Yes, my daughter finally got out of her bed when she was about 9. So I'm not the expert at it, but I do know we have some simple strategies, and most of our families who are having major problems with sleep find that actually the advice of a very non-specialised local sleep nurse, community nurse, is invaluable. Actually, it doesn't need to be rocket science. Movement disorders, is he developing spasticity with the arm, hands flexing, in which case it's exactly the same team and treatments we consider for cerebral palsy with physiotherapy, splints and multidisciplinary team. What did I say about medication for confusion? Poor. Medication for sleep can be quite useful to initiate it, but doesn't maintain it. And melatonin is really the only useful one. Medication treats spasticity poorly. So help, he's become very stiff. Drugs are often not a particularly good answer. They can splice into the care, but you're still going to have to deal with an awful lot of other things. The dystonia is exactly the same. Physio-orthoses and multidisciplinary team. Medication treats dystonia very poorly. The dosage you put in are very sedative. We do use them. That's where the tertiary neurologist may well come in. I'd be very happy to see anybody who's got troublesome spasticity or dystonia, advise on balancing up all the different therapies. So we are making contact with people, but not all the contact, because if all the contacts with me, I find the secondary team don't engage, and sometimes I have to be a bit naughty and turn my back so that they will launch. I've talked about the distress and feeding, but pain, treat the cause. Hey, Medication treats pain poorly in ALD. So let's treat the cause. Let's not be giving a child morphine. Let's work out why they're in pain and remove the painful stimulus. So if they've got a sore bum, we need to think about a different chair or system. And boredom is something that's very important. That's something that was actually critical because a child might have had to come out of school and is suddenly at home on their own the whole time. And that's something we can amend, but we need to think it will be very complicated to get a child who's changing quickly back into school. I am aware that I've concentrated more on boys who are actually deteriorating with ALD, and of course, you know, the whole thrust of this conference is on both prevention with good screening and, you know, the wonderful news on transplant. But transplant's not always fully effective, and all these symptoms, all these kind of checklist of services and inputs that I've described can be used on any child between a very mild disease to a very severe disease. So my important messages are the neurologist cannot and should not lead the team, because what we tend to do then is undermine the secondary person. But we should be able to identify, assemble, empower that team, occasionally with a little shaming. So, you know, you really have to be there. And I think identifying why they might be slow to pick up problems is interesting in its own right. And lastly, it's difficult to plan support if you don't know where you're going. Excuse my typo. And the neurologist needs to educate, talk to people a little bit about the journey. So we do know what's going to happen in the future in many cases, all the things to watch out for, and we can empower things like physiotherapists on what to do, not necessarily by telling about ALD, but telling about conditions which look very similar over the next few years. Thank you.